I'm Dr. Olivia Scheller, Medical Director at the Institute of Medical Education and Research. Welcome to IMA reporting live from American Society of Hematology 2011 meeting. I have Dr. Gail Roboz, who is the Director of Leukemia Program and the Associate Professor of Medicine from the Weill Medical College of Cornell University. Thank you so much for joining us today at the American Society of Hematology 2011 meeting.
Thank you for the invitation. It's a pleasure to be here.
So it's been really exciting times when it comes to acute and chronic leukemias, and what I'd like to go over is some of the new exciting data. There's been quite a few randomized trials that came out at this meeting. Can you go over some of those trials?
Absolutely. I think there's a lot of information from ASH this year which is quite relevant to practicing doctors, and it's also exciting because the scientific accomplishments at the meeting in AML were quite remarkable during this meeting. But first, some of the clinical data. So the first thing that I think is coming out that's very important about AML is that personalized medicine is almost here. We don't quite have personalized therapies yet, but patients are being increasingly divided into specific clinicopathologic subgroups based on their cytogenetic and initial molecular testing. And one of the things that's coming out at the meeting that's the hardest, I think, for clinicians is that there are what feels like a gazillion different mutations being identified in AML. But actually, what was gone over in the education session for AML is that the period of mutation discovery might be coming to a close. The impression is that within the next couple of years, we're going to know all of the different mutations that characterize AML, which is a very exciting development. But it gets better because it seems that there are driver mutations, the ones that really matter, that are going to be identified as prognostically relevant. So right now, clinicians are usually just dealing with FLT3, NPM1, and CEBP alpha. And we do expect that in the next few years there are going to be a couple more added to that list which are prognostically relevant. But what's exciting is that clinical trials are being designed currently and are available currently that divide patients into different therapies based on some of these molecular findings. For example, a large clinical trial was presented from Germany following up on some previous work looking at the effect of ATRA, or all-trans retinoic acid, when added to conventional chemotherapy in patients with an NPM1 mutation. And as their previous data had suggested, they actually do show a survival benefit for the addition of ATRA to this subgroup of patients, again, specifically those who are NPM1 mutated but without a FLT3 ITD. These are findings that can't be applied immediately to clinical practice, but they do suggest that patients with that particular molecular background should be treated possibly differently from other patients. The other thing is that the FLT3 inhibitors are being developed to try to make that target a more robust one in AML. Previous data on the FLT3 inhibitors had really not been that convincing, certainly not a story like imatinib in CML. But if we get a better drug and a better target, which is actually what Brian Drucker said at one of the keynote addresses in ASH, we might be able to make this particular tyrosine kinase inhibitor work better. The results of a large randomized trial looking at a FLT3 inhibitor in combination with chemotherapy in AML were not yet presented at this meeting, but that trial actually just closed to accrual. It's called the RATIFY trial. At this particular meeting, what we saw were randomized data looking at a couple of drugs that are, I guess, in the older category. So once again, there were randomized data looking at different doses of cytarabine in AML. Cytarabine and how much to give has been argued over for the last 30 years plus in AML, and unfortunately we still don't know the right answer. But I think the message is that the total aggregate dose of cytarabine given in induction and consolidation probably does matter, and higher doses seem to benefit younger patients. I would still say that for the clinician, giving high-dose Ara-C to older patients doesn't help. It has increased toxicity, and once again is not supported in clinical practice. Another area, maybe a controversial one, of clinical trials that came out at this meeting involved gemtuzumab ozogamicin, which was voluntarily removed from the market several years ago due to concerns over safety from a SWOG trial. And that drug is actually a very interesting one, and there was a lot of controversy when it was removed from the market. And actually, the flames are being fanned now because randomized data from France and from the MRC suggested that in subgroups of patients, the addition of low doses of gemtuzumab had a survival impact in AML. It's really hard to get anything to get a survival impact in AML, and candidly, the data for older patients haven't improved in the last 30 years. But in these two trials, there was an improvement observed, and the first one coming out of France, which was presented at the plenary session by Sylvie Castagne, showed that in patients 50 to 70 years old, the addition of 3 doses of 3 milligrams per meter squared of gemtuzumab did result in a survival benefit. Now, depending on how you view these things, it wasn't a huge survival benefit, and there was still a risk of veno-occlusive disease in a few patients. But the question is really, is this enough to drive consideration of somehow trying to revive this drug and to bring it back? And I think that is going to be a subject of a lot of discussion. I would point out, though, that these trials, which showed the benefit, did not use escalating doses of the anthracyclines in combination with gemtuzumab. And for example, data that have been presented in the last couple of years did show that for patients under 65, accelerated or intensified doses of daunorubicin did result in a survival benefit. So the question is, would that have the same effect potentially as adding gemtuzumab, or could they even be added together, or is gemtuzumab better? I would just point out also that particular drug, gemtuzumab, has remarkable efficacy in acute promyelocytic leukemia also, and I think many doctors would be excited to have it available again so that we could use it for those patients.
Were there any other abstracts at ASH that seemed to be interesting that may change the face of treatment for patients in AML?
I think there were. I think a couple of worthwhile notes for the clinician. First of all, in acute promyelocytic leukemia, this is a disease where patients are doing exceptionally well. It's our happy place in AML because the survival rates are excellent, the cure rates are high, and there were a couple of pearls that were presented at the meeting that should be noted. The first was that for patients treated in an intergroup trial that was started in the 90s, the data were reviewed and it was found that late relapses are very rare. So the people who are cured are really cured. And not only that, but when there was a late relapse, it seemed to be treatable and the patients would do well again. So that was encouraging news. The other thing that came up, though, was once again the cautionary tale of what to do with older patients with acute promyelocytic leukemia, because they do get into remission. But it's quite clear that if you proceed with the traditional intensive consolidation chemotherapy protocols, you lose patients in remission. And that is a terrible, terrible thing for acute promyelocytic leukemia because in general it's so curable. I think that using arsenic trioxide and lower intensity chemotherapy protocols for older patients with APL was once again supported by data presented at the meeting suggesting that intensive regimens really have increased toxicity among older patients, especially older patients with high-risk disease, an initial presenting white count of over 10,000. Those are the ones who really, really need to be watched very carefully right from the beginning of induction.
Wonderful. What do you think about looking into the future of AML? What's the current direction of therapy for AML?
So I think, I guess we can talk about that in two ways. The first thing is what are the new drugs, and the second thing is what's being understood about AML pathogenesis that can help us to apply these new drugs. There was definitely a selection, as there always is at ASH, of novel agents, but I think what was really exciting was a proliferation of abstracts, both in the clinical sessions and in the basic science sessions, on how to look at minimal residual disease. And I think this is a very interesting area. Most hem-onc people know that in acute lymphocytic leukemia, in ALL, maintenance chemotherapy for a prolonged period of time after the intensive portion does result in a survival benefit and is completely standard of care. In AML, even though we know that the bad cells are left over after remission for sure. And data presented at this meeting again confirmed that if you find bad guys left over after remission induction, even if you transplant patients afterwards, the rate of relapse is high. And yet there hasn't been a maintenance chemotherapy type of program in AML that's been part of standard of care because it hasn't been shown to improve overall survival. Well, at this meeting, there have been a lot of efforts to try to make clinically relevant and usable measurements of minimal residual disease. This isn't standard yet, but it's coming. In Europe, it is already standard for minimal residual testing, either molecularly or by flow cytometry or by both, to check patients who are in remission and to try to get an assessment of how much disease is left over. In the meantime, the question is, are these cells that are left over the same ones as what the patient started out with? Or have they been altered? Have they been mutated? Are they different from what the effects of chemotherapy were? Or have they been altered in other ways so that your treatment after remission needs to have some special sauce? It needs to be different from what the patient got initially. The concept is that novel agents might be added to both induction, consolidation, and then long-term maintenance strategies. And in this meeting, I think several pathways emerged as potentially interesting for this. The first was the hedgehog pathway, and there were data presented suggesting that, first of all, the hedgehog targets might be upregulated in AML and might prove to be either AML stem cell or AML leukemia progenitor cell targets that are relevant in considering how to use hedgehog drugs. I think that the data that were presented were very preliminary, but they suggested, in this case, it was a Pfizer drug that was presented in a very early phase 1 setting of possibly targeting the hedgehog pathway, which is known to be important for stem cell survival. And that's an interesting way of trying to get at cells that are leukemia cells that are left over after chemotherapy that don't typically die with standard chemo. Some of the other novel therapies are ones that may disrupt the ability of leukemic cells to home back to the marrow or to set up shop almost in silos within the bone marrow where they're protected from standard chemo. And there are a bunch of different drugs that might be important. There are several signaling pathways, including PI3 kinase, including Notch signaling, that might be important to target in the future. But the key is to not try to use these drugs, these novel therapies that target signaling pathways alone, because it's almost definitely the case that they'll need to be combined with something else. This is new. You can't practice it yet, but I think it's coming soon.
So there's a lot that we have to keep a look on for the treatment of patients with AML. Let's talk a little bit about chronic leukemias, specifically CML. Has there any data that came out here at ASH that gave any updates? Because we have 3 agents that are approved for the first-line treatment of CML. Has there been any updates and anything in the horizon for treatment for CML?
So the CML story is what we want to have happen in AML. We want to have a target that is like BCR-ABL, and we want to shut it down with a drug and have the cure rates or at least long-term remission rates that we're seeing in CML. The CML story from this meeting is one of success. So the currently available agents had follow-up data presented suggesting that the responses continue to be durable for those patients who are doing well and who have molecular responses initially to nilotinib and to dasatinib and also to imatinib. They continue to do well over time. But there still are patients who either develop resistant mutations along the way and lose their response, or who have the T315 mutation initially, which is resistant to the available tyrosine kinase inhibitors. I think everybody is interested in the new ponatinib data, suggesting that both for 315 patients and for other patients who are no longer responding to the available agents, that there's a new guy on the block who is going to be helpful. And I think that the data suggests that this is a highly active and well-tolerated drug that will have a role for sure for CML patients, hopefully in the near future. And I think the development is ongoing to try to capture those patients right at diagnosis who within the first 6 months of treatment are not hitting the defined milestones and therefore need to be taken off and put onto other therapies, and also to make sure that patients who are doing well, who do hit those milestones, continue to be compliant with their current therapy, because at the moment we don't have a reliable strategy for taking people off of their drugs. So they should be encouraged that just because they're responding well, that shouldn't be a signal to stop therapy.
So this is truly exciting times when it comes to leukemia, and it seems, what you went over, that we should keep an eye on all these newer agents that are coming up, and also keeping up with what's happening with the already available agents for both AML and CML. So I want to thank you very much for reviewing all the exciting data that came out at the American Society of Hematology 2011 meeting. Thank you.